Welcome, everybody. My name is Talia. I am from Practice Health Check. Some of you may have met me through some of the audits that we've done at some of your clinics. Today, we're going to just do a very informal infection prevention and control education session. We want to just sort of highlight some high-risk audit findings and just provide some learning objectives for everybody. So the president of the company is Maya McGuire. Some of you may also have met her. I'm Talia. I'm one of the infection control consultants with Practice Health Check. So we'll start by talking about routine practices, and essentially it's a fundamental for infection prevention and control. So really all patients are potentially infectious even if they do not have symptoms, and then routine practices take into account actions and symptoms that are not based on diagnosis. So you always want to be mindful of your routine practices. And this is really to prevent the spread of microorganisms. You want to ensure that the same safety standards are practiced routinely with all patients in order to prevent exposure to blood, bodily fluids, secretions, mucous membranes, non-intact skin, or soiled items. So as long as you are consistent with your routine practices, you treat all patients that are potentially infectious, treat them all the same, even if they do not have symptoms, then this is really sort of what you want to abide by in terms of the fundamentals for routine practices. So IPAC gap number 1, dental water lines are not being flushed at the beginning and at the end of the day or in between patients. So you always want to make sure you have a goal of less than 500 colony forming units per mil of heterotrophic bacteria for routine dental treatment output water. So the potential negative outcome is if this procedure is not being done, can lead to transmission of bloodborne viruses between patients, for example, hepatitis C. Also shutdown of practice, retrospective notification and testing for patients, and obviously some form of a tarnished reputation. So the solution would be you want to use an approved product for use in your dental unit waterline maintenance and consult your manufacturer's instructions for use for proper maintenance of the equipment in order to sustain the quality of dental water. So some methods to aid in reducing the amount of biofilm are using self-contained water bottle delivery systems, either using distilled water as your source water, using sterile water or saline for your source water when completing surgical procedures, and discharging water and air for a minimum of 20 to 30 seconds after each patient from any device connected to the dental water system that enters a patient's mouth. So handpieces, ultrasonic scalers, those sort of instruments. So biofilm, what exactly is biofilm? So dental unit waterline contamination consists of slime producing bacteria, essentially. So fungi, protozoans, these microorganisms will colonize, so they'll form and they'll replicate on the interior surface of the waterline tubing, inevitably resulting in adherent heterogeneous microbial accumulations termed biofilm. So you could see the various stages of biofilm formation on the inner walls of the dental unit waterline in the diagram here. So as water passes by the dental unit waterline, the dental unit waterline biofilm, it picks up bacteria from that biofilm and flushes them downstream to the patient's mouth. So the good quality drinking water that enters the dental unit can become highly contaminated as it passes through the dental unit into the patient's mouth. So stage 1, you could see that the bacteria adhere to the surface. Stage 2, the bacteria begin to secrete extracellular polysaccharides. Stage 3, they develop sort of this biofilm, which is that slime producing sort of film, and then bacteria released from the mature biofilm. So even if the incoming water is sterile, it's not sterile when it comes out of the patient's mouth. So this is really important to know. So biofilm and you. So how many of you bring a water bottle to work? I assume many of us do, since we're all very concerned about maintaining, hydrated, staying hydrated throughout the day. If you're not giving your water bottle a regular scrub with a bottle brush, or just cleaning it really, really properly, there might be a bacterial storm brewing inside the walls that could potentially get you sick. So if you're just cleaning parts of the bottle that your mouth touches, then essentially your water bottle can be filled with many types of bacteria. So moving on to IPAC gap number 2, dental teams have improper PPE during aerosol generating procedures. So the goal here, the RCDSO advises that all dentists in Ontario should continue to use the COVID-19 enhanced precautions at all times in the dental office. If you're unfamiliar with these enhanced precautions, they are on the RCDSO website under the infection prevention and control guidance documents. So you want to make sure that you have an N95 respirator, which is fit tested for you, seal checked or the equivalent as approved by Health Canada, gloves, eye protection and face shield, and of course your protective gown. So continuing with improper PPE use during aerosol generating procedures, dental aerosols can contain many contaminants, including blood, viruses, bacteria, various fragments. Some potentially negative outcomes are contamination of the operatory environment and potential transmission to the next patient. So when these contaminants are aerosolized, they can land on the environmental, surfaces. And if those surfaces are not appropriately cleaned, they can potentially transmit to the next patient. Also, another potential negative outcome could be high risk exposure to COVID, resulting in a 14-day quarantine and potential COVID infection, and also transmission within the dental team, which can lead to mass exposures and clinic shutdowns. So improper PPE use can mean many different things. It can mean wearing the incorrect type of PPE, so not choosing the appropriate PPE for the procedure that you are performing. It could also mean not changing PPE between patients, so wearing the same PPE from patient to patient, can 100% increased risk of transmission. You always want to make sure that you're using new PPE for each and every patient. Using alcohol-based hand rub on gloves. So I'm sure you guys already know not to do this. So if you're wearing gloves, we're not using alcohol-based hand rub on gloves. And using an N95 mask with valves. So you want to avoid using any N95 mask with valves, because then that just creates two-way airway. So gap number 2 continued. So how COVID-19 is transmitted through aerosol particles. So through coughing and sneezing, you can project large droplet particles that can travel 2 meters in distance, but with aerosols, they can travel much farther and remain suspended in the air. So that's one of the reasons why we use the HEPA units and why we make sure that we have all of the HVAC systems looked at, and we're aware of our air exchanges so that we can sort of minimize this risk as much as possible. So IPAC gap number 3, staff break room is still being used like it was pre-COVID. So the goal is for break rooms for the staff, they must have signage and be assessed for how many staff can be in the room at once. This is very important. So Sitting staff must maintain a minimum of 2 meters distance while the masks are off, and surfaces must be cleaned and disinfected prior to removing the mask and eating. If masks are being reused, they must be placed in a designated place to prevent contamination of surface and the mask. So potential negative outcomes here from having more than the appropriate number of individuals in a break room at one time unmasked, you could potentially have an outbreak in your clinic. You could have high risk exposures and numerous staff on 14-day isolation and transmission of COVID to your patients and your families. So here's just another sort of diagram, the bubble you think you have. So you could see you and then your friends, but then, sort of your friends have friends and they have friends and everyone else, your friends are my friends sort of thing. And then before you know it, your bubble is a much larger bubble. So essentially, the longer it takes for mass vaccination, the more likely we will, sort of see that third wave. And actually, that's what happened. We did see that third wave. So the COVID variants, really are, a lot different than the strains that we were seeing when COVID first started. So the variants are a little bit more virulent in terms of causing more severe infection and hospitalization. So distancing and adherence. So this is a really good example of identifying sort of safe areas within this room where people can and cannot sit. So some tables you see there's two people. It's likely measured that they were 6 feet apart. Also, you can see the X in the middle of the diagram. The person can't sit there obviously because they would be too close to the person behind them, that sort of thing. So we can't stress the importance enough to follow the IPAC measures, even outside of work, reduce carpooling. So if you must carpool, then you must be masked. That's very important. Number 4, inconsistent documentation of sterilization procedures. So for a sterilizer that has a recording device, the physical parameters must be checked at the conclusion of the sterilization cycle for each load and documented on a log sheet. So one PCD with a type 5 or type 6 chemical indicator may be used to justify the release of a reprocessed load. Alternatively, a type 5 or 6 chemical indicator must be placed in each package. So for a sterilizer that doesn't have a recording device, the physical parameters must be checked during the sterilization cycle for each load and documented. Sometimes this is not a sustainable way of doing things. If you have a very old sterilizer or a busy practice, it's very, very difficult to check that mid-cycle. Potential negative outcomes: potentially transfer of bloodborne pathogens between you and your patients. So the requirements also to re-sterilize all dental instruments if sterilization is questioned. Also recall of patients and testing for bloodborne pathogens. Required re-education of all reprocessing staff, and IPAC lapse disclosure by public health unit. So these are really if public health were to enter your clinic and ask for proof of documentation for your sterilization process. They want to make sure that you understand what it is that you're doing. In addition to that, they want to see that you're recording all of the appropriate parameters for each sterilization cycle. So this is one of the most common IPAC gaps noted during audits. It is also one of the IPAC gaps that can easily be fixed. So this is positive news. It is also one of the more serious IPAC gaps that can lead to a serious IPAC lapse disclosure. So these, things, it's positive that it can easily be fixed, but it also can lead to very serious IPAC lapse disclosures. So logs and documentation are imperative to document that your checks and balances are in place and that can be verified. So as I mentioned, public health does want to see that you have a very good understanding of why you're using, the process that you're using and why you're documenting what you're documenting. So it supports the changing workforce, applies to all the reprocessing steps that require a log. So this includes your cleaning and disinfection of your ultrasonic, including the preventative maintenance for ultrasonic or your washer disinfector, and also your biological indicators. So when they're being used, the date, the initial time in, out, positive, negative, that sort of thing. So common audit pitfalls. So USB parameters are only checked and logged at the end of the workday. They must be checked at the end of every cycle. Log is not kept up at all or is inconsistently filled in. So first step is to have a log. Second step is to consistently complete the log. So all fields in the log must be completed every day, every cycle. Also, another pitfall is numerous flash sterilization cycles are noted on the log. Please do not do flash sterilization. It is not best practice and it can actually get your clinic into trouble if public health does observe that you're doing flash sterilization. Also, log sheets does not indicate that you're using a PCD in each load. So this is very important for the clinics that are using a PCD. I always say that your documentation should always tell a story. So I should be able to look at your documentation and tell you exactly what your processes are without you having to tell me verbally. So your documentation should be very, very clear on what process you're doing. So if I don't see any class 5 chemical indicators in your pouches, I'm assuming you're using a PCD. So when I look at your sterilization logs, I should see a column on there that speaks to the use of a PCD and your class 5 chemical indicator. So another pitfall is staff can't speak to what a PCD is when asked. PCD is a process challenge device. It's meant to challenge the process, the sterilization process, and you must read the manufacturer's recommendations on the placement of the PCD within your sterilizer. Also, no columns to record class 5 indicator color change. So this is very important. The class 5 chemical indicator, which is looking at your time, temperature, and pressure parameters, you must record the the color change of that indicator. IPAC gap number 5. So operatory drawers in various states of clutter with dental instruments, endo files, and burrs scattered throughout. So the goal is to keep sterile items in pouches until time of use in order to maintain their sterility. So again, anytime you open a pouch, you've compromised the sterility. It's not sterile anymore. Even if you did not use it, you must re-sterilize it. So items that need to be sterilized prior to first use must remain in packaging until they are transferred to a pouch for sterilization. So I encourage you to familiarize yourself with the various types of burrs that are used in your clinic. There are a ton of various recommendations with the burrs. So some of them you'll notice on the packages, some of them come sterile from the manufacturer, which means you're able to use them straight from the packaging from the manufacturer. Others are non-sterile, and you'll notice that from a symbol in a triangle that says non-sterile. So that means you must sterilize the item prior to use. And some also indicate that they are single use. So they can be single use and they come sterile, or they can be single use and they don't come sterile. So it's very important to know which type of burrs you have so that you're not reusing burrs that you shouldn't be reusing, or you're not using burrs straight from the packaging that perhaps are not sterile. So potentially negative outcomes, unsterile items used on a patient, a used instrument contaminated with bioburden used on a patient, IPAC lapse for unpouched instruments found in operatory, and cluttered drawers can compromise properly pouched and sterilized instruments prior to use. So if you have a very cluttered drawer and you're also storing sort of sterile instruments in there in pouches, if things are really cluttered, it could also compromise the integrity of these pouches. So what we often find in this sort of type of clutter is unknown sticky residues, um, often many years of dirt and dust, potentially contaminated instruments, personal staff items. Sometimes we see PPE that's taken out of clean boxes and stored randomly into drawers. Please do not do that. PPE should remain in their box. So gloves should remain in their box until time of use. Same with masks. IPAC gap number 6, so pre-drawn unlabeled mystery syringes. We don't see this a whole lot, but we have seen them on occasion, so it's worth mentioning. Pre-drawn solutions into syringes are to be done at the time of use. According to the United States Pharmacopoeia 795, preparing these solutions ahead of time is actually a form of compounding. So pre-drying, if absolutely required, can only occur up to 1 hour prior to use, and pre-drawn syringes must be labeled with the compound name, concentration, and time it was drawn up. All syringes which have not been used must be discarded at the end of the day. So potentially negative outcome is bacteria, fungi, viruses, they're all introduced in sterile tissue during dental procedures, flagged by public health as a high-risk IPAC lapse, often paired with other high-risk things like pre-spiking saline bags, entering into multi-dose bottles without aseptic technique, reusing a dental instrument to dispense a multi-dose cream. So these are all really high-risk sort of procedures. So it's important that if your practice does, drawing of any sort of solutions, whether it's saline or sodium chloride for anything, then all of these parameters must be followed. Other audit worthy finds. So you'll see here on the left, the scissors are reprocessed in the closed position, but all hinged instruments must be reprocessed in the open position. So those scissors should be open all the way and pouched and then reprocessed in that way. Also, the brush on the right, it's quite worn. And so we try not to let our brushes get sort of to this state of wear and tear. So it's always important to look at the integrity of your brush. And if it looks like that, then it's probably best to throw it away and use a new one. And also those brushes, they should be sterilized at the end of every day. So it's always a good idea to have more than one brush so that you can rotate through. Also, if you take a closer look, the little red sort of silicone thing in there, it's called a bath buddy. And we've seen those sometimes used in, they sort of bunch instruments together in the ultrasonic. And these actually are not best practice. So when you load your instruments in the ultrasonic, you never want to bundle them like that tightly and secure them like that because it doesn't allow for proper cavitation in the ultrasonic. So you want to always just loosely put your instruments in the ultrasonic. So these two photos here, the one on the left, way too full, way too full. Also, there's several pairs of scissors in there in the closed position. So a good guideline to fill the pouches is when you lay the pouch flat, all of the instruments should line up next to each other, and you should never have any instruments that overlap one another. And the photo on the right, again, I see a pair of scissors in there. Um, Great that the chemical indicator is in there, but it looks like that's a bib of some kind, and those are single use, so we don't want to sterilize those. Same thing with gauze. We don't ever want to sterilize gauze because our sterilizers or tabletop sterilizers in our clinics are not meant to sterilize gauze. They are done in a different way, and not sort of with those steam sterilizers that we have in our clinics. Again, here, some pre-drawn solutions and also several trays, I guess, waiting to be loaded in the what looks like hydrum or possibly ultrasonic. If you know that your instruments are going to hang out for a while, especially if your hydrum is full or if your ultrasonic is full, it's best to have a holding container with enzymatic solution so that you could rest your instruments in there to prevent any of the like biological material from hardening. So just a little bit of background on COVID-19. What is COVID-19? So coronaviruses are essentially a large family of viruses that are known to cause illness ranging from the common cold to more severe disease, such as Middle East respiratory syndrome, otherwise known as MERS, and severe acute respiratory syndrome, otherwise known as SARS. What are some symptoms of someone infected with coronavirus? So you really have your common symptoms, which include respiratory symptoms, fever, cough, shortness of breath, breathing difficulties. And then you have some asymptomatic symptoms, which include loss of taste and smell, headache, nausea, vomiting, diarrhea, and COVID toes. So, after, I guess, how long it's been now, a year, we are still experiencing this. However, the positive news is that vaccine intake is on the rise. And I think as of today, if I am not mistaken, it's about 2 million people have been vaccinated. And every day, the positivity rate and the positive number of cases are going down. So that is a really, really good sign. COVID-19 risks with aerosol generating procedures. So this is an important one. Most dental procedures that use mechanical instrumentation will produce airborne particles from the site where the instrument is used. So dental handpieces, ultrasonic scalers, air polishers, air abrasion units, they produce most visible aerosols. So each of these instruments removes material from the operative site that becomes aerosolized by the action of the rotary instrument. So ultrasonic vibrations or the combined action of water, spray, and compressed air. So as you can see here, I'm sure you're very, very familiar with these instruments and what they do. So just touching lightly on proper mask use. So again, you always want to clean your hands before removing your mask. You want to remove your mask using the ear loops. You want to place your mask outside facing down on a clean tissue or paper towel. If let's say you are having a break for lunch and you'd like to reuse that, clean your hands after you have put it down. You don't want to pull the mask under your nose or your chin. That's not the proper way to, wear the mask. Do not hang the mask from one ear or hang the mask around your neck. You always want to remember that the front of your mask is always contaminated. So if it's not on your face, it shouldn't be on your chin or hanging from your ears. Providing food. So hand washing or sanitizing stations should be available or in or close to the break rooms. So it's important that if you have an area where it's designated to have your lunch or it's a break room, that you have the ability to wash your hands. All individuals should wash their hands before and after entering. Physical distancing should be maintained. Measures may include staggered meal times, which I know a lot of clinics are doing, floor markings to identify safe areas to sit or stand while having a break, and different eating areas. So foods should ideally be individually packaged or not shared amongst staff. All individuals should put their garbage directly into bins and not leave it for others to clean up. Also, disposable plates, bowls, etc., and individually packaged cutlery should be used. So, some occupational health related concerns. So, what do you do if a team member tests positive? So, you want to make sure that if you're the team member that tests positive, you want to let public health know. It's likely that they will connect with you or get in touch with you because they are notified of all positive cases, and they do usually follow up to ensure that there is no risk of exposure to other individuals. So, break room physical distancing, we talked about that. This could be an occupational health related concern if individuals are not appropriately physically distanced, which can, of course, lead to transmission, as we talked about. Also, cleaning high touch common areas and surfaces that staff touch often. So, like the lunchroom tables, phones, other areas like doorknobs, light switches, these are all high risk areas. So, we need to ensure that there is a regular schedule in the clinic to clean all of these high touch areas so that we are minimizing the risk of transmission. So, why have staff in hospitals and long term care homes occasionally acquired COVID? This is a really good question. If you could remember earlier in the year, well, earlier when COVID did first start, a lot of long term care homes were experiencing outbreaks. And there were many, many reasons for these outbreaks. One of the reasons were break rooms. So lunches were not being staggered. People were practicing break times as though, COVID was not a real thing. And so staff would congregate in the break rooms, be too close, unmasked, and boom, you'd have an outbreak. Also, team members, they would come to work sick. Maybe they just had like one very small symptom, which they overlooked and they didn't think much of it, or they were actually really sick and they came to work, which can obviously transmit to other staff and other patients. Also, non-compliance with universal masking. So, just not adhering to universal masking procedures. This can again lead to transmission. Incorrect doffing. So this means incorrectly removing your PPE. So it's very important to know the correct way to remove the PPE and ensure that you are doing hand hygiene in between all of those steps. And so when you're not correctly removing your PPE, you leave room for contamination onto yourself or onto other surfaces, and then risk transmitting that to other individuals. So contaminated environment combined with poor and lackadaisical, lazy PPE practices. So again, we talked a lot about wearing, improper use of PPE. So wearing the same PPE from patient to patient, this definitely increases your risk of transmission, not correctly taking it off, that sort of thing. And also acquiring in the community. So, what is an aerosol generating procedure? Most of you are very familiar with this. An aerosol generating procedure is a procedure where high concentration of droplets smaller than 5 micrometers are generated and suspended in the air. So, I always like to use the example of a aerosol hairspray can. So, often when you spray that can, you can physically see the mist. Generally, these aerosols remain suspended in the air. And this is the sort of concern that we have with COVID when you're doing aerosol generating procedures, is that you have all these aerosols suspended in the air. And because they are such a small particle, smaller than droplets, they do remain suspended in the air for a long period of time. So dentists should avoid AGPs wherever possible. These aerosols can be generated by high speed, low speed, and other rotary devices. We talked about the ultrasonic and other similar devices, as well as air water syringes. So AGPs must be performed in a designated operatory that is capable of containing aerosols. So Many clinics have done a great job in terms of sort of retrofitting their operatories with, barriers that can close in the doorways, sealing off all of the entry points between operatories. So if you have half walls, then sealing those areas so the aerosols cannot travel. Also, installing HEPA units in all of the operatories, and in addition, getting a HVAC assessment to be able to determine the proper air exchanges for your environment. These are all things that are going to help sort of turn over the air in the room a little bit quicker. So AGP capable operatory requirements. So again, floor to ceiling walls, but if you don't have actual floor to ceiling walls, which many clinics don't, they have, done that sort of either plexi or, vinyl coverings to seal all of those gaps. Ability to close the door during the procedure. This is also important so the aerosols do not sort of escape into the hallway. If door is not present, then an alternative barrier must be erected. Removing of all unnecessary items, including artwork and plants. This is really important in order to provide a clutter-free area. So you want minimal clutter on your countertops, removing plants, just because you want to be able to clean and disinfect the surfaces quickly and easily after every patient. Temporary walls and doors are permitted, but they must be constructed of a material that can be repeatedly cleaned and disinfected, and must be installed in a way that allows easy access into the operatory without self-contamination. So this is very important. You don't want to contaminate yourself in the process of entering or exiting the room, and the materials must be made of something that can easily be wiped. So that brings us to the end. I'm going to stop sharing my screen and invite any questions if anybody might have them.